Thanks. Okay, ladies and gentlemen, can we make a start? My name's Pэddi Kostal. I'm one of the directors of Knowledge Action Change, and I'm delighted to welcome you all to what is the final plenary session of this City Health 2018 conference. The topic that we're going to look at this afternoon is health devolution and ensuring public health and well-being at a local level. What we've got is 4 speakers who are going to introduce the topic, and then once each of them has spoken, we will all adjourn to the stage here, and then there'll be an opportunity for question and answer and contributions to the discussion and the debate afterwards. So what I'll do is I'll introduce each of them individually and ask them to make their presentations. I should say that all of the presenters are actually going to present in English. So if people, I speak a form of English, and I hope that those who speak English can understand me, and those of you that don't need a headset. So the first speaker that we've got this afternoon is Dr. Vladimir Kurpita, who is from the Ukraine Development of Public Health System. And he's a medical doctor, and his experience is also extends to having worked for the World Health Organization and for the all-Ukrainian network of people living with HIV. So he's going to describe to us changes to the Ukrainian public health system and its delivery. So please, Vladimir.
Good afternoon. It's hard to speak exactly after lunch to wake everybody up, but I hope that my speech will not bring you to the dream, and we will have a chance to discuss a little bit about the perspective of the public health system in Ukraine and what happened in our country within the health care reform in general, how it will be bring to the health cities, and what is the public health in the broader context of European framework. So I would like to start maybe among the some challenges which was defined by WHO regional office several times and addressed through the several documents, which include the inequalities and economic crisis which country face, the globalization, migration, and urbanization, which impact the health of population on individual and community level. Aging of population is one of the current trends exist in every country, despite the big discrepancies in the life expectancy, which I will show you. And at the same time, the environmental degradation and climate change are one of the most hot topic in the discussion of the politicians and public health experts. But this climate, all these determinants lead to the emergencies which affect the public health system, and simultaneously this emergency followed by the increasing role of non-communicable disease due to the lifestyle behavior and emerging and re-emerging infection disease. So when we look at the life expectancy data groups, there is like 2 issues I would like to focus you on. The first one is that the expectancy is growing starting from 1950 till 2050, and that means that aging is becoming more important topic to be addressed through the healthcare. At the same time, when we look at the specific area, specific age, okay, different countries will achieve specific lives at different stage. And this discrepancies is in life expectancy within the European region is one of the main issue to be addressed through the public health. To summarize all factors which impact the health of population, I would like to maybe remind such documents, such graphs, which include that our health under the influence of environmental and social and economic determinants. And this include the issue regarding the heat waves, fires, droughts, chemical spills, and also the food security, which cause to the changes in the infection diseases habitat. When we talk about the social and economic determinants, in addition to aging and inequalities, we should remember about the technologies which from one side improve the quality of life, from another side could affect our lifestyle and also impact the health status. At the same time, these two major health outcomes, which is now addressed by the WHO regional office and by Ministry of Health, is the life expectancy and increasing prevalence of non-communicable disease exactly caused by this lifestyle. At the same time, there is a huge implication on the health system in general, which is related to increased cost of the treatment and increased demand for the treatment because of first of all, improving diagnostic technologies, and also because of increasing the age of the population. At the same time, every country, including Ukraine, observed the decrease in the workforces, which shorten the ability of system to provide care. That's why the public health issue is quite important, because it's based on the solution which includes the risk and projections, the research which prove our theory, and also some innovative solution through the implementation simple and easy to use technology at home or in the primary health care. When we talk about the evolution of public health system in Ukraine, modern Ukraine, because the former Soviet Union has their own system which was mainly focused on the protection of the role of the government and state rather than the person and individuals. It started in 2014 when the government decided to reorganize former SAS, which was responsible for such an activities. In 2014 and 15, during this transformation period, a lot of assessment was conducted together with WHO, ECDC, European Commission, CDC Atlanta, and USAID support. And working group in the Ministry of Health was established, which started to develop the new concept of public health. This concept was endorsed by the government in November 2016, which is give a start for the transformation of public health system. At this time, also the formally public health center was established and core personnel was hired to the public areas. We defined eight priorities where the public health center is now working, which include improving surveillance, introduction of new principles to the health education, improving research capacity of the center, emergency and preparedness plan for the whole country, starting with the prevention program funded by the government, revision of the lab network for public health, starting with the new communication principle and health promotion and blood safety, which is now becomes the responsibility of public health center. At the same time, there was 5 gaps, which include the inefficient national policy, which requires significant changes, and we applied for the technical assistance to our international partners and hope we'll got it soon, especially through the European Commission project, which are coming next year. The human resources, which is at this stage also aged. The average age of the person in the public health center at the beginning of this year was over 60 years old. And we need like a new wave, new generation who could come and interesting in the public health. Revision of legislation, which is outdated, and we terminated about 26 orders and regulation which exist from 1920 and regulated some public health aspects already this year. Finance and budgeting, because the new approaches on the procurement of these services is very necessary and in line with the broader health reform. And also the, as I mentioned before, the poor communication with the population and health professionals. There was like a 6 objectives which exist for the public health center till 2020. Among them, the endorsement of new public health law instead of 42 laws, codes, and the regulation exist, and they sometimes contradict each other. The support of to the regional public health center network, which is now starting to develop. They introduce the new surveillance framework, not only for infection disease, but also for non-communicable disease. Specific NCD action plan, which include improving the physical activities, healthy nutrition, fighting with the high blood pressure and cardiovascular risk, and some other activities. The public health network strategy revision. At this stage, we operate with the inefficient more than 800 public health laboratories. And the workload of these laboratories measured between 3 till 51% maximum. And also to establish the 24/7 preparedness unit to address the emergency to the population. Out of them, there is like 6 internal objectives, which are now aimed to on the introduction new management standards, improve safety procedure and standard operation procedure for laboratories, launch the staff development plan, fix financial management, improve IT knowledge and skills of the staff, and improve internal communication, which was initially not exist at all. So at this stage, our some kind of the achievement for 2018, we are now applied to the cabinet with the amendment to budget program on 1420 and 1040, which aimed at the financial projection for 2019 budget. This will give us the possibility to procure public health services in the different stakeholders, not only the state actors, including NGOs starting from 2019. This was happened because the amendment was done to the budget code in 2017, and despite this amendment will become mandatory from the 1st January 2020, some changes will be applied in 2019. At the same time, government in general, starting with the multi-year planning and budgeting, which help us to solve issue with the such programs like vaccination, hepatitis, HIV, and tuberculosis. The law on public health is already drafted, passed through the public hearing discussion with the regions, and now submitted to the government, to the cabinet for their approval. If this, we suppose that during September, October, we pass through the whole bureaucratic issue and enter the parliament with the new law. We launched the field epidemiology training programs, which is the first innovative training programs for epidemiologists in the country, and hired the first cohort, which consists of 16 epidemiologists. and master curriculum framework was recently approved by Ministry of Education and Science. At this stage, network of the Public Health Center exists in the 6 regions, where the National Public Health Center invests 6.2 million Ukrainian hryvnias, and our plans to establish this Public Health Center in 3 years, which will cover the whole 25 regions of Ukraine. When we talk about the legislation and regulation, there is at least any progress which exists. We are very proud about the several strategies we suggested to the government, include the immunization strategy, hepatitis elimination strategy, national AMR action plan, and blood safety strategy. Instead of having the 3 to 5 years programming, we are talking about the 10-year strategy, which will divide it in the 3 years budgeting process. In terms of the national surveillance strategy, the strategy itself, an action plan has been drafted. We revised the list of the notifiable disease, decreasing them from 157 till 57, about three times, and suggested decentralized surveillance model, which was approved by the steering committee of the Ministry of Health. And there was like a long discussion regarding changes in the lab network. Instead of having 800 across the country, we agreed to have a 25 regional lab center and 4 national one, which will be located in Kiev, Kharkiv, Odessa, and Lviv. To do that, we passed through the VISN model to evaluate and assess necessary staff for the network. We do have a lot of partners, which I would like to thank everybody for the technical assistance and support provided to the Public Health Center. And our logo become like a time to choose health. That's welcome to Public Health Center website, and thank you for your support.
At the first City Health Conference, we had the incoming director of Public Health England speak to us, and I'm afraid that he didn't have quite the same grasp on the plan for public health as you appear to have. So I can only say congratulations to the Ukraine on something which is, it looks very, very comprehensive. If we can move on now to our second speaker, who is Dr. Ingrid van Beek, who is the director for many years now of the Kirkton Road Centre in Sydney and has worked in prevention and treatment for disadvantaged populations, including drug users, for a very, very long time, and was the person who headed the medical team that opened the first safe injecting facility in Sydney. So I'd invite Ingrid now to come and address us on local solutions for local problems. Is it really that simple?
Thank you, Patti, for that introduction, and thank you for inviting me to speak on this issue. It is, in fact, the first time I've specifically spoken on the issue of devolution. I've always been, for 30 years, I headed up, as you mentioned, the Kirkton Road Centre, which was the government's headquarters in Sydney's King's Cross, which, if you've ever been to Australia, that is the area which has long been the centre of the sex and drugs industries in the country. It was established, Kirkton Road Centre was established by the government as its as having its public health responsibility for the vulnerable populations centred in that area, and I've had the privilege over many years of being the director of that service. And so long enough to experience the changing tides in our approach to health, It does seem in Australia, like maybe other countries, that just now and then the government decides it wants to restructure the health service. So we go from centralised approaches to devolved approaches back to centralised. And I suppose in 30 years I've lived through quite a few of those, and pleased to say I've survived. But public health most certainly is the thing that has needed to be sustained throughout those structural changes. So I give a perspective from someone who's worked at the sharp end of public health in this particular area. So what it tends to, devolution, what that tends to refer to is the decentralisation of public policy decision making, usually along with budgetary control. Started in earnest in the late 1990s, right across certainly the Western world. Usually enables different models. I think the United Kingdom, with its different areas, is a good example of the different types of models that are possible. Also, though, complicating, generalising about this approach as far as whether it's good, bad, or other. It can involve various spheres of government, not just health, but it's certainly in healthcare that there's been special interest, and I think that's connected to the burgeoning health budgets in affluent countries with ageing populations. And as already flagged, ensuring that public population-focused health is maintained has been a particular concern when these sorts of structural changes occur. In Australia, the way the health system is structured, it's slightly complicated and not all that logical necessarily. Public health has been the responsibility of central government, federal government, based in Canberra, whereas hospital-based services have been the responsibility of the states. Meanwhile, primary health care has been funded on a fee-for-service basis at the national federal level, and is covered under a universal health insurance system referred to as Medicare. We've had triennial or 3-yearly strategies, national strategies developed for HIV, Aboriginal bloodborne virus and sexually transmissible infections, hepatitis and drugs. And they first started being developed in the late 1980s. The federal government would give the states money to address those, to implement those strategies on the proviso that the states would match that money. So they had to match the investment from the national level. And the funding would come with obligations to monitor and achieve nationally set key performance indicators for each of those strategies. So in that way, they controlled the direction of those national strategies. However, we are now moving away from 3-yearly strategies, and in fact, the current national drug strategy is a 10-year strategy, the implications of which we're yet to see. So my talk is going to pose many more questions than it answers. I'm more or less going to scope what the issues might be. I don't come up with any answers for you, but I suppose the central message is the need for balance in our approach. So the questions: how does the state decide how these resources will be allocated? Is it based on the size of the state's population? Is the population's demographic profile factored in? For example, the age, Indigenous status. In the case of Australia, we have a very significant Indigenous population with significant public health needs, and that is not a population that is evenly distributed across the states and also not within the states. So are economies of scale factored in? So is it just on a per person basis? Maybe the bigger states like my state of New South Wales should get less because we can enjoy economies of scale. Is the current and the future disease profile considered? So the needs of the state's population. Do we then measure the outputs, i.e. the activity of health services, or do we measure the outcomes? Outcomes, of course, much more difficult to measure from a public health physician perspective, much more important than activity. So how do we measure those things? Which things are measured? Are surgical waiting times, for example. That is something that hits the front pages in our country all the time as something that's of great concern. Waiting times in emergency centres is another thing, but arguably more politically important than from a public health point of view. We rarely see the incidence of HIV in vulnerable populations covered on the front pages of our newspapers. And how do we respond to the non-achievement of those outcomes? Do we penalise areas that don't achieve outcomes, or do we give them more resources so that they're better able to achieve those outcomes? Or is it all just historically based? It's a zero-sum game. There's only so many resources, so increasing resources for one area necessarily means reducing resources for another. Anybody that's worked in the health system will know that there are very strong interests, I hesitate to say vested interests, but moving resources away, particularly from the medical profession, of which I'm a member, is very, very difficult indeed. How is the appropriate balance between disease prevention, health promotion, and acute short-term and chronic long-term treatment and care decided? So yesterday, Jeff already put up these 7 words. So these are obviously relevant to how political all of these decisions can be. The banned words there on the left, Kevin Drum, a political satirist, has suggested replacement words. I'm not sure that this will translate very well into Ukrainian, but at least the English speakers might know what I'm getting at with a somewhat tongue-in-cheek facetious slide like this. So yes, it can be very political. I'm sorry, I just need to check back. Sorry, no, we're on track. See, I even worked. So the advantages and disadvantages of localism. So localism being a terminology referred to when decision-making is devolved to that local level. So arguably, it's more responsive to local issues. Local stakeholders with the greatest understanding of local conditions are able to proceed to apply locally appropriate solutions to local problems, unhindered by those less acquainted with their situation. And certainly my experience as the medical director of the medically supervised injecting centre established in King's Cross was a good example for me of where a local solution was appropriate for a local problem. We had all stakeholders on side in that local area, but the fact that it had to go to state level because legislative change was required meant that we had a raging state debate. People in areas unaffected by drug use were worried that an injecting centre would be established on a street near them. And in this instance, I felt very strongly that it would be more appropriate that local government have jurisdiction over this type of facility. But on the other hand, there is a risk of parochialism. This localism approach is less top-down. It encourages grassroots initiatives, such as the injecting centre in my case, and it also potentially allows for greater autonomy, but there is the risk of local areas going rogue. It's so in the same vein, it's arguably more democratic, responsive to the voice of the people in the local area, but does that in fact favour populist views? Is the loudest voice at the local level always the majority voice? And is the majority voice always right? In the case of the injecting centre, we did polling of local opinion because we found at community meetings there would be very loud vocal opposition to this. What we found when we did random telephone polling in the area was in fact that those voices were not representative at all of what the local population thought. In fact, they were very supportive of an injecting centre. And I'd have to say that evidence, unlike some of the other scientific evidence, was very compelling for local politicians of all colours. Once they knew that 80% of the local population supported this thing, interestingly, there was multi-partisan political support for establishing this service. But what if the results had been different? What if the local population had been unsupportive? Would that have meant we couldn't have gone ahead with this important public health initiative? So what is the role of professional, expert and those with lived experience versus local community stakeholders? Very commonly in local communities, there's not a voice from the affected community. Drug users are not always well positioned to have a voice at that local community level, particularly given that the behaviour is still very stigmatised, illegal. It's unsurprising that they're not necessarily sitting at the table. So who represents their voice? Those are important questions. Who has the final say? Advantages continued can encourage healthy competition. When things are devolved to the local level, I think in the UK, in the documents early there, it was referred to as constructive discomfort. Do you like this political spin language? Especially if combined with purchaser-provider arrangements that can create a lot of competition at the local level between organisations vying for limited funds. That is a risk, therefore, of reduced collaboration and partnership approaches at that local level. On the other hand, it may engender greater collaboration if there are limited resources. Maybe we are more inclined to work together rather than risk duplicating things. We look at ways to complement one another better and engage in partnership approaches where we share the resources and enhance intersectoral and horizontal service integration at that local level. So we need to identify exactly where the final responsibility lies as well for these imperatives. Performance and funding agreements need to be clear about where the accountability lies for the expected outcomes. But at the same time, those agreements need to be flexible enough to respond to different and changing needs at that local level. It can also encourage the development of scientific, technical expertise and leadership at that local level. But in countries with remote areas, and Australia, of course, is a country with very remote areas, it may just simply not be possible to move expertise out from the central level to the local level. So there's a risk also in moving expertise outwards that you hollow out the expertise at the central level. So you go back to having bureaucrats that are career bureaucrats without necessarily having technical expertise. And when I think about the early response in Australia to AIDS, I think the bureaucrats that I worked with were fantastic. And when I think further, I think that's because they were personally committed and passionate about the area. And I'm not sure that career bureaucrats necessarily do. So unless quarantine, public health funding may be exposed to local budgetary constraints, forcing it to compete with more immediate needs, acute care services. I was on the local health authorities board, and every meeting this played out as I pushed for prevention and health promotion, and they worried about people waiting in the emergency centre, which, as I referred to before, was much more likely to end up on the front page of the newspaper concerning the minister. So the Cinderella health fields, as I call them, were stigmatised, often hidden populations, homeless, sex workers, alcohol and drug dependent, those living with HIV, TB, hepatitis, mental health, prisoners, those with disabilities, they are most at risk. The risk? Someone's taken the slides out. Sorry. Simple? So sorry, I am missing some slides here. Maybe it was those humorous slides that wouldn't have translated so well. Okay, so the importance is, as I say, to achieve the right balance. Nurture political leadership at a local, state and national level, develop methods to measure outcomes and establish systems to monitor these. Develop and communicate approaches that are knowledge, science and evidence informed. Support structures that encourage effective advocacy for such approaches by the affected communities and other expert voices at all levels. and educate the broader community about the societal value of achieving the right balance between prevention, treatment and care, and short and longer term health needs to ensure health for all. Thank you.
Okay, thank you, Ingrid. Our third speaker this afternoon is Dr. Vioral Soltán, who is originally from Moldova. I first met Vioral early in this century, about 2001, when he worked for the Open Society Institute, and I was engaged in work in prison drug services in the European network. And I'd like to think I had some effect on his career, because since then he's moved on through various incarnations to his current role of the head of the Stop TB Partnership country and community support team based in Geneva. And he's going to talk to us today about ending TB starting at the grassroots level. So, Vioral, please invite you to take the stage.
Thank you, Pэddi, and good afternoon. I'm very pleased to participate in the city health. This is first time when I'm taking part in this important forum, and I welcome very much the fact that TB is getting more attention on the agenda for the local authorities and for those partners that are working at the local level to bring TB on their health agenda. It's a very timely, I would say. Basically, in a week from now, in New York is going to happen the first ever most important meeting dedicated to tuberculosis. It is about high-level UN high-level meeting on TB. It's on 26 during the General UN Assembly, and I would say that this is a first time when UN bring tuberculosis at that agenda. Those who knows HIV had already 4 meetings like that. The first one was in 2001. So 17 years later, we came to discuss tuberculosis. So I would say that we lost 17 years in terms of getting more ambitious and getting more bigger commitments to end TB in the world. Those who are from HIV, we have been discussing this morning that there are a lot of wording and approaches that we used in HIV are currently present in TB agenda as well. We also talk about 90-90-90 targets, and it is about like to reach 90% of who are in need, and those who are in need should be 90% out from key population groups, and to achieve at least 90% of treatment success in those covered. So these are the targets of the global plan to end TB. Which is part of the bigger end TB strategy. When designing the programs on the ground, when looking what we can do at the local level, of course we need to embed and to arrange all our programs to be in line with what is happening in the world. And currently, if looking on tuberculosis, there are about 10 million people estimated to get TB annually, and we only find about 6 million of them. So 4 million still are not notified by the health systems, and that's a big problem at the global level. If to look on drug-resistant tuberculosis, we see that we miss out of 600,000 estimated. We find only roughly about 100,000, so 500,000 are missed as well. If to look on how successfully we treat those who we diagnose with TB, you see that 1 in 2 is successfully treated when we talk about susceptible TB, and 1 in 10 is treated successfully when it is about multi-drug resistant tuberculosis. So there is an initiative called strategic initiative supported by the Global Fund at the global level to find those missing people with TB, those 4 million that I mentioned. And in this graph you see the biggest contributors in the world in terms of those cases. You will see Ukraine as well in here, because maybe for our region it is not about missing people with TB, but it is about to diagnose them earlier. Our biggest problem in the region is we diagnose people with TB at the late stage of the disease. So basically, if talking about the interventions, they are the same. In terms of find them early, it means to do active case finding, or to stimulate active case finding. I just wanna show you which is the problem at the global level, and to see that one country from our region, which is Ukraine, is also part of this strategic initiative, and also received the catalytic funding, which is additional funding to the country allocations from the Global Fund to catalyze activities in terms of early detection. Looking on the cascade, because those who are from HIV also very familiar with this wording, right? Looking on the cascade in terms of TB, HIV co-infection, you see that we have about 1 million estimated cases a year, and we diagnose TB, HIV co-infection in less than a half. And we provide antiretroviral treatment in about 39% of those who are in need, which is also a big problem at the global level. Recently, the Stop TB Partnership and WHO developed a joint initiative which is called 40 by 22. It means to find 40 million people and put on treatment by 2022. And the targets have been updated to be in line with the recent surveillances that we had. So when we talk about the activities that we need to develop at the ground, that we need to develop at the local level, because basically when activities are aggregated at the national level and then at the regional and at the global level, we talk about that primarily the local level is very important, right? Because the TB, we call that TB pockets are there, right? So when we approach TB, it is about to approach this in a comprehensive manner. And we say search, treat, and prevent. Very often we forget that we need to prevent. We have a big problem in terms of latent infection, and we need to do screening of the latent infection, and we need to do prevention of the active disease in those groups. There are some examples around the world that active case finding and comprehensive approach in terms of search, treat, and prevent works. And I have a few slides here showing some experience in the United States, in Tomsk, Russia, in other in Karachi. I would like to mention that we, together with the Alliance for Public Health Ukraine, we are part of a regional project called Cities. In 5 cities in the region. It is about Odessa, Belts, Tbilisi, Sofia, and Almaty. And Stop TB Partnership is a technical partner in this initiative. And together with the Alliance for Public Health, we are trying to bring the new approaches and the new thinking and strategies to work at the city level, at those levels that we, as I said, call them pockets for TB. It is important to say that we Stop TB at the global level. We lead an initiative called Zero TB Initiative together with Harvard University and other partners, and we do these approaches at the global level, and we have a very good examples in the world where we have local authorities and city authorities achieving great results at the ground by approaching comprehensively the TB issue by search, treat, and prevent. When we say comprehensively, we would like to mention few issues which are very important at the moment when we build this at the local level. It is about to build our programs around the people, because around the people who are in need, because they are those who are basically requesting the services. So we in TB started to address more and more the issues of key populations, because somehow the TB world didn't explore this sufficiently in terms of having key populations in TB. And currently we identified more than 10 key populations to be addressed right now, and working with the countries in terms of mapping and prioritizing those populations at the country level. It is about addressing stigma and discrimination and reducing human rights barriers to services. And I mentioned this morning, and I will say again, that in tuberculosis we didn't use human rights perspectives in our asks, in our advocacy. We didn't say it's our right to have access to new drugs, to bedaquiline, to telamine. It is, we don't say it is our right to ask. It is our right to have access to gene expert and so on and so forth. What we did a lot in HIV field. And of course, it is about reducing gender-related barriers to services. So this is a very comprehensive approach, and we recommend this to do at the local level as well. We have, as I said, we have few very well documented practices already. It is about One Impact digital tool that we are rolling out in 12 catalytic countries plus Cambodia and Tajikistan. Right now, it offers people a means to be engaged. They do a social monitoring, they do they increase their literacy and they participate in the day-to-day work at the grassroots level. We work with the civil society and community to embed them more in TB, because TB is very, very reluctant to bring civil society and community on board compared to HIV still. And it is also about to have support, financial support as well. We have currently the Global Fund still present in some countries in our region, but also we see that there are gaps, and those gaps should be in time taken over by the local and national authorities. So that's very important when we design those programs, think in advance and allocate money, additional money. We already have a lot of examples when the local authorities support a lot those search, treat and prevent activities at the ground. So as a conclusion, it is important to improve the demand of the services, to increase the asks for the services, to accelerate the uptake of the preventive therapy, to increase allocation and use of funds, to address and remove barriers to services. It is important very much to change the mindset when we do that. And of course, it is about to think about accountability at the local, at the national, and at the global level. Thank you very much for attention. And
Thank you, Vierel. The final presentation before we have a discussion in this session is going to come from Дэйв Макинтош. David is the head of community safety for the richest square mile on the planet in the City of London. And he is also the lead for the London Drug and Alcohol Policy Forum. And most importantly, he was one of the founders of the City Health Network in 2012 and has also hosted 2 editions of the conference. And he still looks young. And I don't know how he manages it. But he's going to talk to us about issues to do with drug policy and drug service delivery in London.
Thank you, Paddy, I think, for that introduction. When I talk about localism here, that's a term used a lot in England, and it is devolution. So in the context I'm going to be talking about, localism is pushing things down from national government to local authority. Now, this is going to be very much a personal overview of really a drug strategy and the provision of drug services over quite a period, but particularly focusing on the more recent times and the impact in London. And just as a bit of background, London has a population of just over 8 million, and we have 33 local authorities, 33 municipalities in that area. And as Paddy kindly pointed out, mine is, I suppose, the wealthiest, but it's all historic and we look after it very well. I'm going to outline how we moved from a very ad hoc system to a very centrally managed system, how that system evolved, and how we've moved to localism as a central government priority, but all that against a backdrop of reduced resources and also fundamental changes to how our health system is structured. And over that period, I've worked at both national, regional and local authority level. And it would be fair to say that my opinions and views have fluctuated over who knows best as I've moved around. Now, up to the 1980s, the UK had very few drug services. London had only a couple of clinics in the National Health Service. There were some doctors who were involved, and there were some charitable providers. We had hugely varying approaches. The evidence base was almost non-existent, and there was almost no central oversight at all. And I pressed the wrong way. That one, okay. And then this happened, And the fears of the impact of AIDS suddenly got politicians very much more interested. And it wasn't just around HIV/AIDS, but we had growing use of heroin. There was growing numbers of people injecting, but overall drug use was also increasing quite rapidly. It was no longer a minor issue that only affected a very small number of people. And so there was a government response, and I seem to have jumped a slide, but I'll go with that. So the government did actually start, the 1995 government did produce a drug strategy that set a lot of responsibility on local authority areas of bringing together partners to work together. Very little money, but there was a recognition that local areas could bring together local police, local social services, local health providers, housing, and that they were well placed to do stuff. But there wasn't any money until we get to 1997. We've got a new government. One of their priorities is going to be tackling drugs. They bring out their own new drug strategy. It's going to reduce the harm that drugs cause to society, including communities, individuals and their families. That's quite an ambitious target, but it is to be fair, it was going to be matched with resources. There was very little central infrastructure. It's in this period that I moved into the drugs field and moved into the Cabinet Office, where there was the United Kingdom Anti-Drug Coordination Unit, which had quite a grand title, but at the time I worked there had all of 7 staff. So not exactly an enormous bureaucracy. And the idea really was that we would try to do some central direction and local authorities would somehow cobble it all together and make it work against the national targets. What we did have was one of these. Every home should have one. A cash tap is a tremendously useful resource. I like telling this to my colleagues who are perhaps a little younger than me now, but there was a time when the biggest problem civil servants had was spending money. We had an additional £200 million just given to us and told to spend it quickly, and there was more that followed that, and it was actually quite demanding because we were starting from a very low base with very few services, but it would definitely come under the heading of good problems to have. But it did cause problems, but at that time drugs also had a very important resource. It had political capital. Drugs were important. The Prime Minister spoke about it, ministers spoke about it, and at the local authority level, chief executives of a lot of councils or someone of that level would chair the local drug action team. It was one of the key local structures. I skipped another slide. There is one thing though, if you're handing out lots of this, ministers and central government gets very, very sensitive about how it's being spent. If you're putting millions and millions of pounds out of the door and giving it to local authorities, you want to be very clear on what your money's buying. And we started to build a bigger and bigger architecture of central management, expecting people to reach specific targets. And one of the good things though is that we could expect a minimum level of service at a local level. And one of the big targets that we had was around doubling the number of people in treatment and improving access. And that was done. This slide here shows very clearly just how much waiting times dropped for people seeking drug treatment. And actually in a London context, this hides the fact that for many people, once they had contact with a drug service, you could actually access services in days, which was a huge change from 98, 99, when it wasn't at all unusual for people to have 6-month waits in some parts of the country. So you could see some of what the money was buying, but we did get increasingly demanding at the centre of what we wanted. and it was very focused. It was very difficult for areas to break away and do their own thing. So in some areas, they might have specific drug problems or issues perhaps, say, with alcohol that did deserve a response, but you could only spend the money that was coming from the centre on what the centre said you could spend it on. And we built quite an architecture around that. We established a national treatment agency, which had a lot of strengths, but it did limit what local authorities could do. At the same time as we were getting increasingly centrist, our politicians were talking more and more about localism and the desire to push things down to the local level, because as we've heard earlier from Ingrid, there is a lot of attraction and, it's very democratic to let people locally decide. But it wasn't even just something that was happening in England. This is from the European Monitoring Centre on drugs and drug dependency. It was an idea that was popular at the time, and it has got a lot of strengths. But at the same time that we were talking about this, we were micromanaging local authorities. And actually, we had 198 indicators on which every local authority in the country was measured on by central government. We were actually spending an awful lot of resource on reporting back to central government what we were doing with the money they were giving us. It had become quite resource intensive. Now, obviously, celebrating is not quite the right word, but there's been a lot in the news today about the 10th anniversary of the big crash in 2008. The cash tap got turned off very quickly. 2010, we get a new government and we've got an official policy of austerity. The National Treatment Agency, who had been very, very important in monitoring and directing spend and local activity, were merged into the new Public Health England body, which had a very different role. At a local level, public health became a function of responsibility of local authorities, but there was massive reductions in funding, and in many ways these continue. We also had a tier of regional government office structure before 2010. That went. In London, we still had the Greater London Authority, but didn't have a tremendously important role, to be honest, around health issues. So where are we now? I did speak to a number of my colleagues who are responsible for delivering drug services in their areas, and I think this pretty accurately reflects what a lot of them feel. There is a lot of confusion and uncertainty about quite where we're going. We've got an increasing variation in quality of service and access to service across London. We still have 33 local authorities commissioning services. Some areas are still very interested and prioritise drugs. Other areas not so much. They really are doing the broad minimum. And in some ways it's understandable. If you're struggling to pay for services for your senior citizens, how easy is it to prioritise funding for drug users? If you think of the crude political maths, where do you get your votes from? We also nearly lost HIV prevention work in London because no one seemed to think it was their responsibility, but fortunately that was such a big issue that was kind of noticed and picked up late on. But it shows that when we broke up the system, gaps emerged. Now, I wouldn't blame it. We have a big increase in drug-related deaths. There's a poster outside which highlights that. I don't think we can blame that on localism at all, but it hasn't helped in some ways, because I'm sure if we still had central monitoring and sort of leadership around drugs, I think there would have been a stronger national response. And to be honest, I find it rather shocking that 2 years of very high increases and we're only really now beginning to think, is there something more we could do about this? We've lost a lot of our service providers. We have far less charities providing services. We've lost a lot of the specialist services that were embedded within our national health system. And that's a real concern, because although consultant psychiatrists are very expensive resources, but they are very valuable when you need them. And I do wonder where we're going to find that specialism within our main health systems in 10 to 20 years, because they're just not winning services to provide. They're not winning contracts to provide services in London, because pretty much whoever can pitch the lowest for the service is going to win it. So there's a very local, how do I get through my next 3 years contract approach, rather than where are we going strategically. We're in a position, there's been a lot of work in London done around hepatitis C. We've got a number of organisations, including NHS England, that are signed up to eliminating Hep C by 2025, but I'm not entirely sure how we're going to achieve it, because the mechanisms don't seem to be in place to deliver that on the ground to me. I'm sure we will, but I think it's going to be done on the goodwill and enthusiasm of key individuals, not because there's a structure there to support it. So, what's my feelings around localism and indeed the central approach? I think they both have their risks. I think it's very clear that it's important that we do all we can to ensure that areas have appropriate and accessible services. And in many ways, local areas are best placed to work out what their local community needs, but sometimes perhaps they need some encouragement externally to ensure they do that. Individual local areas aren't going to keep producing, or aren't going to produce significant evidence base. That's a national function. That's something that needs to be coordinated and promoted and given credibility centrally. Money is very important, but I think that the biggest thing really is around political leadership. We've got, as I say, if you like, a patchwork quilt in London now. There are some areas where there is good political leadership. People are still very keen to do what they can. In other areas, the quilt is getting very threadbare, and it does feel a little bit like we're starting to slide back quite quickly. Things are undoubtedly better than they were in 1998, but in a lot of areas they're not as good as they were in 2010. I think we probably moved too quickly. I think transition can take time. I think in England there was almost a flight of responsibility by some of our central agencies and senior civil servants. We just sort of went, I know it's all down to you locally now. You've got the budget, we're off to do something more interesting. And I do worry about the Cinderella services. It's not just drugs, there's others. A lot of local authorities haven't really taken on board their leadership role, or haven't embraced the role they have around commissioning. So I think localism has an awful lot of advantages. Devolution does bring services and decision making closer to the people, but it does require strategic leadership, and it does require political leadership. And I think that's probably in many ways almost as an important resource as having your cash tap, as having money to spend on resources. You need leadership and you need support, and I don't think all of that can be done at a purely local level. Thank you.
Right. Thank you to all of our speakers. I think they've covered quite a number of issues, and now it's time for any comments or questions from the floor. We've got about 15 minutes, and I'm going to invite all of the panel to come and join me up here on the stage. So I think there's people in the audience with microphones. I hope there's somebody in the audience with microphones. Right. So, anybody like to ask a question or make a point? Yeah, gentleman at the back. At the back? The back?
Sorry. Виталий Рабичук, Молдова, сообщество людей, употребляющих наркотики. Меня интересует вопрос по поводу децентрализации в контексте снижения финансирования. На мой взгляд, я увидел, что существует риск о том, что предоставление услуг может быть отказано на основании того, что услуги будут предоставляться определенному кругу людей, которые относятся к определенной местности по существованию прописки. То есть, другими словами, это может повлиять на внутренних мигрантов. И в частности, я говорю о людях, употребляющих наркотики. Как избежать этого риска?
Thank you. Who'd like to take that one first? Can you use the microphones on the table? You've obviously asked a very good question.
I didn't get a lot of this question.
Okay. Right.
Я попробую ответить на русском. Мы немного путаем вопросы децентрализации, предоставления услуг и прописки. Потому что, наверное, в каждой отдельной стране это будет иметь свой отдельный контекст. Были очень интересные доклады из Лондона по поводу тоже элемента децентрализации, который они называют локализмом. Но это вопрос, который касается, в Украине этот вопрос идет, например, в контексте большой реформы административной, когда децентрализируются не столько услуги, сколько децентрализируются налоги, которые остаются у местной власти. Таким образом, местная власть может более оперативно реагировать на потребности той или другой количества населения. Безусловно, в этом подходе есть свои риски, которые необходимо регулировать, оценивать и выполнять. Именно для этого и существует гражданское сообщество, которое должно смотреть в том числе за выполнением вот этого вопроса равенства, о которых все очень много говорят.
Anybody else like to take that one?
I mean, we certainly do have an issue in London that not everyone, some of our migrant populations, do not have access to publicly funded services. So there is, that's a big, obviously it's a huge barrier to trying to engage with people and help them. And that causes an awful lot of frustration. And in many ways, certainly from the health perspective, doesn't make a lot of sense.
Anything? No?
Maybe to add a little bit in terms of because that's a very important issue, because usually the local authorities cover those who are living in the local area, right? They don't cover those who are not living in the community, and that's the biggest problem in terms of how to manage financially, because the flows should make a equalization, and this is why we call these approaches as equalization funds. When money follow after the patient, right? So there are sometimes at the national level different funds that can do this equalization, but this is a very sophisticated in a way. I mean, usually at the local level we have those funds to cover at least the emergencies in that respect. So it's a way to think and work further on these aspects in terms of how to move money between the local authorities, let's say.
Thank you. Does anybody else have a question? Yes, the lady in the middle. Thank you.
Thank you very much. My question is for Vioral Solthan. Thank you for your presentation. I would like to know what is the role or how much importance is placed in the treatment of latent TB infection. You've not mentioned it at all, and I hear there are changes, strategic changes in how to approach that.
Yeah, you actually mentioned the problem on the latent TB infection, and this is coming very bold in the global agenda and in our strategies as well. This is why we say it is important to do a comprehensive approach. Is not to diagnose and treat, but also to prevent, which we didn't do much before. And there are currently a lot of new technologies in place, which should be demanded. As soon as the demand is bigger, then we have leverages to negotiate prices at the global level. For example, we have 3HP, which is used now to do a prevention of latent TB, which can be scaled up. And we can start, as we discussed in this morning, we can start with those groups that we already cover. For example, people who are HIV positive, and to start to screen TB and do 3HP, at least in those groups that we already cover and we have sufficient programs at the ground. So it is important, and we need to address that, and we have the necessary technologies. The problem is we don't ask. I mean, the communities, the civil society, the countries don't ask for those technologies, and these technologies are still expensive at the moment. But we need leverages to decrease the price.
Thank you, Vioral. Is anybody else with a yes, gentleman at the middle there? Thank you.
Yeah, I'm just wondering about what has been said in the panel about the disadvantages for the local political level, that it might be difficult to show political leadership. For me, the arguments that were named as a disadvantage at a local level are equally true at any higher level. Because at that level, you still have to have the debate whether you build a highway or do something about drug prevention. So I don't feel that the discussion on any political level in itself is easier on a national level, because public health will always have to fight with other priorities on any political level. So I was kind of wondering how the panel would reflect on that.
Ingrid? Dave?
I would recognise that those discussions are had, but I think and this is based on my experience, it's very easy for some individual London local authorities to say that we don't have that problem. If you take that up to London-wide, it becomes a ridiculous argument, and even more so at national level. So I think, and if I go back another example, I have had conversations with people in specific London local authorities who've told me they don't need to think about drugs because they don't have that problem in their borough. I wish there was a London borough that didn't have a drug problem, but there aren't. But they will say that because the numbers are so small, or so not visible to them, or not on their political radar. If you can elevate that to the higher level, then I think people do acknowledge, and it becomes harder for that to happen. But I accept your main point that there'll always be other priorities, and that national politicians would quite like to do something else often as well. But in my experience, I have come across quite a few examples of local areas saying, we don't need to do that, we don't have that problem.
Yeah, I'd support that. I also appreciate exactly what you're saying, but I think the further away from the coalface you get, the more politicians at a national level, for example, are able to think in terms of the greater good. And having a national AIDS crisis is something that no country wants. But yes, at the local level, the temptation is to say, even in our area, that, well, these drug users, they're not really from our area, they're from another area. So those other areas should provide services, and then we wouldn't have a problem in our area. And I suppose the local politicians are sort of less shielded by their political parties' positions. They're more exposed to local stakeholders. It can be much more brutal and combative at local community meetings. And a weak local politician is maybe more tempted to roll over to those loud voices at a community meeting than someone, as I say, at a national level who can have that sort of more population focus.
Two final questions, one here and then one at the back.
Yeah, I also have a question about this localism, and now I want to give an example of the Netherlands, where I live. And there's a lot of decentralization going, so municipalities get a lot of responsibility now for youth healthcare. And one of the reasons for that decentralization, although it's not said like that, is budget cuts. So that it is cheaper to do things at a local level. But the effect is that you get a lot of competition of service providers, and that a municipality ends up with offering cheap service and of low quality. Is that your experience as well?
Well, I think that point was actually very well made by David too, that there is that sort of competition and to drive price down, and that is indeed why governments quite like this. But the sort of things perceived as kind of premium or luxury services, such as a psychiatrist, are easily dumped in order to drive down the price to win that contract. And although the impact of those things might not be felt, in 1 month or in 6 months, I suppose people like us would think that ultimately there will be a price to be paid. But by then that politician will already have gone through another election. And yes, they're less likely to have those sorts of concerns, I think.
I think, yeah, we've had some very poor experiences. I do worry about the loss of specialism. I also, and something I didn't mention in my speech, is that we've seen an increase in what I would call the misuse of unpaid volunteers. And volunteers are really important. They're a great way to connect to your local community. But I would say that we actually are taking advantage of both them and the people they're trying to work with in a number of areas. They're not trained, they're not supported adequately either. But they are very cheap. At least they appear to be cheap when you're putting your bid together. Whether they're cheap if things go wrong, I suspect not.
Final question.
I just want to add.
Sorry.
I think the issue regarding centralization and localism is not only regarding the political leadership. So personally, I would like to acknowledge the role of the new technologies in the implementation, even the public health services. And if we evaluate the progress of public health through the centuries, we are now observing more and more services which become individual despite it influence the community level of health. So it's quite complicated issue which need to be discussed, but it's not very is it positive or negative, and whether this is done by the local authority or the national authority. It's also influencing, a social media sometimes is now playing more important role in the promotion of health or addressing the issue even with the IDU rather than the decision of local authority. So I think it needs to be addressed through the discussion, but I think it's more complicated than either a political decision.
Спасибо большое. Когда в первом докладе говорилось о том, что мы должны свои аргументы на площадках, принимающих решения, когда мы конкурируем за устойчивые модели или прогрессивные модели предоставления услуг, говорилось о том, что нам надо использовать общественное мнение. И я полностью согласен для того, чтобы строить свои аргументы. Но как вы думаете, имеет ли смысл на площадках, принимающих решения, использовать аргументы, основанные на доказательной медицине и научных данных? То, что я заметил в презентации Виорела. Спасибо.
Thank you. Just 1 second, we've had a few problems with the translation equipment.
I'm on my third headset.
Could you repeat the question? I'm sorry.
Я спрашиваю, что кроме общественного мнения для построения своих аргументов на площадках принятия решений, имеет ли смысл того, чтобы использовать аргументы, построенные на доказательной медицине и на научных данных? Потому что общественное мнение иной раз бывает, используется политиками с целью популизма.
Ответ yes или да. На этих площадках мы должны использовать evidence-based evidences. Мы должны использовать доказательные факты. И желательно это делать. Поэтому очень важно, поэтому и мы обсуждаем здесь, как правильно балансировать между политическими аспектами и уже доказательными аспектами, которые техническими, скажем так. Это очень важно. Поэтому очень важно на локальном уровне, вот когда мы работаем на локальном уровне, важно брать технические аспекты или тех людей, которые работают технически, связывать с политическими людьми и найти общий язык. Это очень важно. Но ответ это да, обязательно.
Ну, если я правильно понимаю вопрос, то есть сомнение, что политики могут использовать доказательные данные при принятии решений. И они больше или чаще принимают решения, основанные на популистических идеях, то есть эмоционально, нежели обоснованно. Я точно могу сказать, что это нет доказательств такому утверждению, то есть вот доказательных данных, эвиденса под это доказательства нет, и это обратная сторона медали, когда эмоциональный вопрос как бы сложно ответить. Но наша задача, как я уже пытался рассказать, вот в Public Health задача попробовать транслировать медицинские термины и доказательства в политический язык. Он отличается, поэтому очень сложно иногда говорить с политиками, но надо научиться это делать.
Thank you. It's been very interesting. This is the first City Health Conference we've ever had simultaneous translation. And I'd just like to say, before thanking the panel, I'd like to say thank you for the translators' efforts, because I think that's made everything work exceptionally well this afternoon. And on behalf of the organisers, I'd just like to say thank you to all 4 panellists. I think it's been an excellent session. I think there's been a lot of issues raised. I know that at some stage in the not too distant future, all of the presentations in English and in Russian will be placed on a website. And also we'll have some film of the various sessions, so that if you missed anything, you hopefully will be able to see it again. So if I can ask you all now just to give a round of applause to our speakers. And if I can ask you to be back here in 25 minutes for the final session. Thank you.